Our module A of the course was primarily to give you a basic idea and an overview of my system and its extended application. We have understood that in degenerative lumbar spine, we need to cover a large area including symptoms, the correlation of symptoms with pathology, the correlation of symptom pathology and the images, and then act on those images in 6 symptom groups. We have already covered the 6 symptom groups in my matrix, and these are primarily knee, heel, groin and coccygeal pain, facet-related back pain, disc-related back pain, disc-related sciatic pain, and then of course the stenosis, which is claudication in a stable spine or claudication in an unstable spine. After having a general overview, which was primarily prepared for people who are already doing endoscopic spine surgery, where they could probably directly go to module C, where they will be going into details of surgery, we now come to module B, which is a very basic understanding of my system and why it was devised like this. So, assuming that you are a beginner and you are very new to the idea of doing transforaminal endoscopy, let us start talking about module B, which will cover the very basics in a very extensive way for understanding the application of my system to degenerative lumbar spine in all its symptoms and presentations. Now, when we start talking about this, you need to be ready with a piece of paper or your diary and a pen, so you can simultaneously make notes. You can also pause my video in between and then go in for your thinking or your visualization, so that this course becomes much more effective and helpful to you. So let us start. Now, as you have realized, whenever we talk of any new system or any new way of treating a condition, we need to identify the best fit patients where we can apply this understanding. So initially, what we are going to talk about is the assessment and choosing a right patient, which will roughly include these following points. The points are, why is it that the patients come to us? The answer is primarily they come to us for pain and for claudication because of various changes which are occurring around the spinal nerves and the nerve root axilla. The dural sac and other structures which include these nerves also have changes occurring around them, but more about that a little later. We have already covered the matrix where we have talked about 6 groups of symptoms. Then we will emphasize how we distinguish between the chemical and the mechanical, or the mechanical and the chemical causes which give rise to pain and claudication. Then we have to talk about how do we make decisions in patients with back pain with respect to their activities of daily life. We also would cover claudication and the importance of knowing when to act in these patients by doing interventions based on the presence or absence of neurodeficit and the use of ultrasonography to understand the effect on the detrusor or the bladder function. We will also highlight the use of counseling videos for the patients, which we also need to internalize so that we are in one line or on the same page when we are referring to these conditions. I would also highlight the normal frequently asked questions by the patients, which I have already covered on my website drgoreonline.com, and you would be shown how to transliterate or translate by using the Google tools the material which is already present in your own language, so that you can utilize this fund of knowledge to convince your patients. Then we would cover the comorbidities which are likely to be present in these patients and which are limitations for our interventions, in addition to some built-in limitations of our technique. Then we will roughly or gently cover the risks and complications with our technique, which can easily be avoided because, as we have mentioned before, we are not following a trial and error methodology, but we are following a method. We are following a certain understanding of the whole picture or the big picture. We have to also understand here that all our system is based on the narration by the patient and therefore has certain limitations which have to be overcome, where we need to sift the falsification from the basic important part of the data. So let us start.